The Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between.
Well, hello again, and welcome to the Pediatric Lounge. This is your host, Dr. Herb Bravo. And with me is Dr. George Rogo, our co-host. And today we have a phenomenal guest, Dr. Eric Bricker. He has a distinguished career not only as a physician, but also a genius in finance and economics of healthcare. He has the most entertaining and informational video, not only on YouTube, but also on LinkedIn, which explains all the conflicts of interest that healthcare has when it comes to finances and economics and how they impact the work that we do every day in the exam room. Please help me welcome him.
George, how are you? I'm joining you not from Italy, not from Fort Lauderdale, but from Woodbridge, Virginia, near Potomac Mills at my friend's office, Dr. Oscar Sergati.
Oh, so you're working like a real doctor like me, I guess.
I am. I'm trying to live up to your dream.
Yeah, but when I do podcasts, I do them from Italy or Florence or France or Florida or something else to make it more interesting. Who cares about a doctor's office? Well, it's Tuesday once again. And like we usually do on Tuesday mornings, we have to elevate great physicians. And I stumbled upon Dr. Eric Bricker, another great physician, through LinkedIn. Some of you may have seen him on LinkedIn with his videos about the finances of medicine, with his cool little whiteboard, which I found very interesting. So take it away, Herb.
Hi, Eric. Welcome to the show. I'm a fan of yours. I love your videos on LinkedIn. I'm so curious to figure out, how do you get 100,000 people to follow a finance guru on LinkedIn?
Well, you gentlemen are so nice to have me on your podcast. Thank you so much for having me, and thank you for everybody for listening. I am hardly a guru, but certainly for, I went to the University of Illinois for medical school. I did my residency at Johns Hopkins in Baltimore, and not once was I ever taught about how I was going to get paid as a doctor or how the money worked. Like that whole part was left out. And I'm sure that there are medical schools and residency programs in America that probably do talk about that, but probably not a lot. And so I was like, well, let's actually educate physicians and nurses and everybody in healthcare kind of how the money works, because at the end of the day, whether you like it or not, the money has a huge impact on patient care. So I'm interested in healthcare finance because it has dramatic implications for patient care. But to the extent that that's interesting to people, then they kind of watch my videos.
Yeah. And so, Eric, do you have an MBA or you're a CFA? I'm just trying to figure out if you had formal training in finance.
Great question. So I was an economics major undergrad at Northwestern, which means that I know enough to be dangerous. However, I graduated in 1998 during the internet boom. And I was kind of sick. I was pre-med, I was kind of sick of studying. And of course, in 1998, they were giving away jobs like crazy. You couldn't not get a job graduating from college. So when I graduated from college, instead of going straight to medical school, I got a job as a hospital finance consultant. So I actually worked in the billing and business office of major medical centers like the University of Kansas, the Cleveland Clinic, Yale Associated Hospital, because doctors and hospitals have a huge time with their accounts receivable with getting paid. So they hire outside consultants to show them how to do that. So I worked for one of those consulting firms. And this was all during, Healthcare and Bill Clinton. And it was like, okay, healthcare is a disaster, but Healthcare and Bill Clinton's going to fix that. Well, that didn't happen. And so I was like, okay, well, I need to learn about this because I don't have any doctors in my family, but I volunteered at an ER, just wheeling patients to radiology, whatever. And every single doctor I talked to said, whatever you do, don't go into medicine, because the HMOs and managed care and the government, they have ruined the practice of medicine. And so I'm like, okay, well, I got to learn about this if I'm going to go into medical school. And so that was long-winded answer. That was my sort of business training. And it was, I learned all about the coding and all about, back then, the only electronic payer was Medicare. Literally every other payer was trifold bills that you put in an envelope and you sent it through the mail to get paid. So anyway, long story, that's my background. That was my introduction to it.
Yeah, that was called the HICFA 500. Remember that? Oh my God. You used to use whiteout when there was a mistake on it. Oh, geez.
Yeah.
That's right. And so the facility bills were the UB 92s and the physician bills were the HICFAs. And you could always tell by their color because the UBs were pink and the HICFAs were blue. And that's how you could easily differentiate between the two.
So this mess, I'm a somewhat little bit opinionated, but this mess all started with President Johnson when he promised every dying 65-year-old that they would have hospital care. You have a great video on the story of that and how that put us on the wrong track, and we have not recovered.
Yeah, so I thought the same thing as you, and the story ends up going back much further. So the desire for a, let's just call it, single payer, universal coverage. It actually started with FDR. So as FDR's New Deal during the Great Depression, he actually wanted to have universal health coverage and a healthcare safety net as well. And it was highly opposed by physicians in America and a whole bunch of other folks too. And FDR really wanted Social Security. So he scrapped his whole universal healthcare idea. And it's like, fine, like I'm not even going to fight that battle because I really want Social Security. So he was able to get Social Security passed. But that whole idea, it really has been championed by every single Democratic president since FDR. So actually Truman and Kennedy also wanted to do it as well. And so I thought that it was quote unquote LBJ's idea, but it was not LBJ's idea. But what happened was that there was a landslide Democratic victory in 1964. And so not only did you have Johnson get reelected, but then you also had Democrat control of the House and the Senate. And so that's what actually then allowed them to pass. And it wasn't even called Medicare. Medicare was the media term for it. And then it just stuck. They're like, well, we don't know what to call it. And so, all the news agencies and newspapers, they call it Medicare. So like, fine, that's what we're going to call it. And it was really two separate pieces of legislation. And one of those pieces of legislation was called the Kerr-Mills Act. And then there was another piece of legislation, and they combined those two pieces of legislation. And that's why you have two separate things called Medicare Part A for hospital coverage and Medicare Part B for physician coverage, because they had to reconcile those two different pieces of legislation when they created it. So anyway, I could go on forever about this story, but that's the short version.
So what did they get right? The thing they got right is they, it's like Operation Warp Speed. They poured billions and billions of dollars into the healthcare industrial complex, which has given us MRIs, functional, MRIs, PET scanners, minimally invasive heart surgery. You can replace a valve now through your groin. All these medical innovations were funded by the amount of money that was thrown into it. But there is no, every action has a reaction. So the reaction was we built a complex that loves to spend money. That's right. And doesn't care about quality.
That's right.
And so that was the original sin.
That's right. And that was essentially the institutionalization of fee for service. The way that they, because every doctor in America didn't want it, but the way that they were able to get it passed was like, look, we'll do fee for service. And then in the beginning, the doctors and hospitals could charge whatever they wanted.
Why is that?
And Medicare would pay it.
But why is that? What's the term? They used to pay 85%.
Higher use demand.
They used to pay you 85% of usual and customary fee schedule.
Oh, usual and customary.
So if I charge $1,000 for a well child exam, Medicare would send me back $850 check.
Yeah, but was that reasonable? Was that fair?
It wasn't. That's why then the AMA came up with the CPT codes and the IVU values, because it was unaffordable. I mean, orthopedic surgeons were charging $20,000 for a hip replacement, and they were getting $16,000 from the government. It was a flaw in the design, right? And
yeah, so it was going bankrupt way too quick. And part of that was when then Reagan put in the whole DRG prospective payment. service, because back then hospitalizations too, they would hospitalize you for like a month and a half, because the longer you were hospitalized, the more you get paid. And then when they put in DRGs, then the length of stay and the number of hospitalizations just fell through the floor, because they wouldn't get paid some sort of open-ended blank check for hospitalization anymore.
Yeah, so that was a big flaw in the design. And there was no thought to preventive medicine, and there was no thought of medications. So we would pay for your heart open heart surgery at the Bakers Institute in Houston, but we wouldn't pay for your Lipitor or your beta blocker, so you don't end up on the operating table.
Right.
Yeah.
Genius design.
Check for screenings.
Genius design. Genius. Just geniuses.
That's right. And there was so, as you can imagine, there was so much money in it, to your point, that there were constituents, or just organizations, businesses, all sorts of groups who were making so much money off of it that they were going to do everything they possibly could to either preserve it or to skew it in their favor as much as possible.
Yeah.
And then I want to ask you, because I kind of understand, but I don't really totally understand. You were the CMO at a company called Compass.
Correct.
Compass or Comaps?
Compass.
Compass. And that company's mission was to save employers money while maintaining quality. Is that
yes.
Right? Okay. What was that like? Did you enjoy that job?
Yeah. So the way that this came out was that when I was in my residency, I stayed in touch with one of my consulting colleagues who had become the EVP of finance for a major hospital system in Texas. So he was actually responsible for billing and collecting $3 billion a year in hospital revenue. And he had 1,000 people reporting to him at the age of 27. And so, total billing disaster, confusing, yada, yada, yada. You don't need me to replay the story. I was seeing the same thing at the patient bedside. Everyone's like, none of my doctors talk to each other. It's so confusing. I don't know what to do. Prior authorization, denial. I can't get an appointment, yada, yada, yada. So my co-founders, Scott, Cliff, and myself were like, let's start we didn't call it healthcare navigation, but essentially so much of what pediatricians do and family practice doctors do and internists do is care coordination. And of course, there's not really, quote unquote, bill. You can't really bill for it, right? And so to a certain extent, a lot of primary care doctors, frankly, don't do it as extensively as they should because they don't get paid for it. And so we're like, look, we will just do the care coordination. We won't do any of the clinical decision-making, but all the paperwork and the prior authorizations and the appointment scheduling and the yada, 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 figuring out with your insurance, like we'll do that for people and we'll sell it as a service to employers, because we've realized, I'm like, oh, okay, a lot of people actually get their health insurance through their job. So we actually would sell it to employers and they would add it to their employee benefits package. So you would get your dental insurance, your vision insurance, your medical insurance, and you would get your Compass healthcare navigation service to kind of be the personal healthcare administrative ninja to help you with that. And we had folks that were on the phones, and we had, an app, and you could, use our website, et cetera, and we would take care of all of the administrative stuff in healthcare, billing problems, et cetera, so that just the patient and the doctor, they could just focus on the clinical stuff at the bedside. And this coincided with the growth of HSA plans, and what happened with HSA plans is people's co-pays went away. And then all of a sudden they had this deductible and co-insurance. And of course, like nobody understood that. And so companies would hire us to be like, look, none of our employees understand their health insurance, and they're calling our HR department like crazy. And they call the insurance company, and the insurance company is no help. So we're just going to have them call you. And we're like, great, that's what we exist for. So we grew that to about 2,000 employer clients, about 1.8 million people. We did it for Southwest Airlines and T-Mobile and McDonald's and a bunch of sort of mid-sized companies between like 200 and 2,000 employees. And so really it's a thing now. Like the entire healthcare navigation space like exists. Like there's other companies that specifically provide these navigation services. And we sort of acted like an ombudsman, because what happens with patients a lot is like their bill gets screwed up or their prior authorization gets screwed up. And the doctor's office is like, well, you need to call the insurance company. That's not our fault. And then the insurance company's like, you need to talk to your doctor's office because it's not our fault. And so the patient's like stuck. And so we were like the third party ombudsman to be like, look, regardless, we're going to own it and we're going to fix it for you, regardless of quote unquote whose fault it is. And sometimes it was the physician's fault and sometimes it was the insurance company's fault, but we didn't care because we were just going to solve it for the patient. So anyway, that was another long-winded answer to your question.
And then now you have a company called AHealthcareZ. What is the mission? What are you trying to accomplish there?
So what I did at Compass was I was the externally facing sales, marketing, account management guy who I was constantly meeting with employers and HR people and CEOs and CFOs. And they use something called a broker benefits consultant to put together their benefits package for their employees. So all I did for 11 years was meet with these people. And at the end of the day, the vast majority of them really do not understand how healthcare works. And so here they are. Now, it's kind of like the golden rule, right? He or she who has the gold makes the rules. So the employers have the money, like they're spending all the money. So this is one big misconception. I think most of your listeners are very smart and they realize this. Like insurance companies don't have the money. They're just like Visa or MasterCard. Like they just process the transactions. The money is the employer's money. So when you think you're socking it to the insurance company, like you're not. You're socking it to the employer. The insurance company does not bear risk. They actually just administer the claims. It's the employer that's actually bearing the risk. And so they've got the money, they're bearing the risk, and they don't understand the risk that they're bearing. They don't understand patient care. They don't understand how the money flows in healthcare themselves. And to a certain extent, like all I would do for the last 11 years is kind of explain to them like how healthcare really works. And they're like, oh, no one ever told that to me before. And so what AHealthcareZ is I'm like, okay, well, I sold the company in 2018. And I'm like, okay, well, I'm just going to make all these videos that actually explain how it works so that whether it's physicians or startup companies or whatever, whenever they talk to employers, the employers then have some baseline education and some context to be like, okay, well, I understand how like my PBM is keeping the rebates and increasing the price of my medication spend. So if you're coming to me with some sort of like new PBM that like doesn't do that, then I kind of understand how I'm being taken advantage of so that I have a better appreciation for the solution you're trying to offer me.
Sounds like a job that the medical directors are supposed to do at the insurance companies. The PBM.
Yeah, but so you're right, but they're conflicted. And so they have not been, and you know, I won't get into conspiracy theories. Some people will say that they have not been, that the employer customers have not been appropriately educated by their carrier, just because the insurance carriers are so large, right? And there's, you know, and you know, you only essentially have 4: Blue Cross, United, Cigna, Aetna. And so when you don't have a lot of competition, you tend to be more sort of complacent in terms of not giving as good service to your customers as you should. And then there's, you know, other people that say, well, actually, you know, it's an intentional conspiracy to keep their customers in the dark and confused and to intentionally not educate them. So regardless of what the underlying reason is, like they just don't understand.
Yeah. So the last real mission-driven, value-driven CEO of an insurance company was Mark Bertolini at Aetna. And, you know, he merged with CVS and then they quickly booted him out.
That's right.
They didn't want to hear about wellness and investing in people. They, you know, like you said, the business model for the insurance company is best when they act like Visa. I take a little chunk of every transaction and there's billions and trillions of transactions every day. A little piece of it amounts to big profits for them with no risk.
That's right. And with this medical loss ratio that it's 15%. And so you're thinking, okay, well, MasterCard and Visa, they keep maybe 4 or 5%. Essentially, the insurance carrier is MasterCard and Visa, but they get to keep 15%.
Yeah, it's crazy. So this administration has passed a lot of money into the pockets of Americans. And one of them, they call it the American Rescue Plan. What are your thoughts about that? What was it, another $1 trillion in money?
Yeah, so the American Rescue Plan, so short answer is yes. The American Rescue Plan was one of the first pieces of legislation that passed when the Biden administration came into office. So we were still in sort of the throes of COVID, if you will, in the beginning of 2021. And one of the biggest things it did from a healthcare perspective is it provided larger and more extended subsidies to the Affordable Care Act, or the Obamacare plans. And so this has been a major problem for the ACA and Obamacare plans, because they did not have any sort of perpetual funding source, right? Medicare has a perpetual funding source in that they added the Medicare tax, right? That everybody pays out of their income tax and employers pay out of their payroll tax. So that's, but Obamacare did not have that put in place. And so they essentially always have to allocate more money on a go forward basis in order to keep paying for that. And so the American Rescue Plan did that. Now, the issue is with that is that the Affordable Care Act, or the Obamacare plans, no longer are required for people to have. In other words, you used to have insurance, or you were going to get penalized on your tax return. But Trump got rid of that requirement. So not everybody has to sign up for a Obamacare plan. So what happens is what's called adverse selection. So generally healthy people who don't have insurance through their job, et cetera, let's say they're in their 20s and their 30s, they just don't have insurance, and like they don't get penalized for that. Like honestly, like if you're like a healthy person and you're not going to have a kid in your 20s and 30s, like the like actuarially, like chances are you're not going to have any medical problems, and you're not going to file any claims, and you're not going to go to the doctor, and you're not going. So why would you pay like literally $8,000 a year? It's like a used car a year for something that you don't need. So people are like, I'm not going to do that. And so what happens is that the only people that sign up for ACA, I shouldn't say the only people, the vast majority of people that sign up for ACA Obamacare plans are people who have medical problems. And who are some of the biggest group of people that have medical problems is people who are on dialysis. Right. So if you're on dialysis and you like lose your employer sponsor coverage, and Medicare because Medicare doesn't have to pay for your dialysis for 3 years. So you can go into end stage renal disease, and Medicare doesn't start paying for your dialysis for 3 years. And so like one of the largest drivers of spend for Obamacare plans is just the payment for dialysis.
And what is the other story behind that? I got 2 comments on that. So why does Medicare cover dialysis? Does anybody know?
Why don't you tell us?
Because it's the right thing to do?
No. So one of the senators' wives, I don't remember when, this is like 50 years ago, got on dialysis, and he thought it was unconscionable. He had to pay the bill. So he got it as a rider, and now Medicare covers it. And the other interesting story is DaVita, which is the biggest provider of dialysis in the country, is owned by United Healthcare. So that's where the conspiracy theories start. The United Healthcare supports the ACA, and donates money. Then all of a sudden they buy DaVita, and then all this money's coming in, and they're making money from the premiums, they're making money from the dialysis, and it's just all money going to their pockets. So I
do need to make one point of clarification. So United only owns the DaVita physicians. They don't actually own the DaVita dialysis centers. The DaVita dialysis centers themselves are an independent, publicly traded company. However, who is the largest shareholder of DaVita? It's Warren Buffett. So, and that was part of the reason why he was conflicted with the whole Haven Healthcare thing, because Warren Buffett actually makes more money the more people that go into end stage renal disease. So if you're a shareholder of DaVita, you actually want more people to have kidney failure.
It's it's the conflicts of interest, and it's just amazing. So anyhow, so they put a lot of money to correct the mistake that was originally in ACA, which was very expensive plans that don't fit the young. And that money went into the economy, and now we have 10% inflation.
Well, that's part of it. I mean, they printed a whole bunch of money, they sent a whole bunch of checks to people's homes, but yeah, you put it all together and you get inflation. Yes,
but so again, every action has a reaction. There's no free lunch. The politicians love to sell you free lunches, but there are no free lunches in this life.
That's right. There's somewhere I heard that if you roll a stone, it rolls back on you. And if you dig a pit, you fall into it. So yes, that tends to happen.
Like that.
Yeah.
So we're going to do a bunch of quick questions, a bunch of stuff I just don't like. Are the HEDIS quality measures worth anything, or are they just process measurements?
So that's a great question. Of course, I made an AHealthcareZ video on HEDIS measures. It's actually, if you either search on YouTube or even if you Google HEDIS measures, my video shows up. so NCQA runs HEDIS. So if you search HEDIS, like my video shows up before the NCQA video shows up. It's just like me with a whiteboard. But HEDIS measures are really interesting in that, one, it's only claims based. So that's the first problem, is that, and there have been lots of studies around this, and at the end of the day, the claims themselves are not an accurate representation of what's clinically going on with the patient. So if you're measuring quality based off the claims, well, to a certain extent, you're not measuring it accurately. So that's one problem. And then the other problem too is that they actually do have a combination of process measures, and they actually do have outcome measures as well. But those outcome measures are also based on the claims. Now, how can you tell an outcome measure based on the claims? Because there's CPT codes for controlled versus uncontrolled diabetes. There's CPT codes for controlled versus uncontrolled hypertension. Well, shoot, if you're a doctor, I mean, everybody knows how the doctors bill. I'm just checking things off, like whatever. I might mischeck it. My check mark might be kind of big instead of kind of small, right? And so when the coder is looking at, which code it is, or maybe the doctor wasn't even paying attention, right? And so without actually looking at the A1C, that's not what HEDIS is not going and doing EMR extractions from doctors' offices, EMRs. They're just looking to see if you checked off controlled or uncontrolled diabetes on the billing code. So it is a measure. I think that there are definitely things about it that you can measure in terms of okay, well, you can measure certain process things around gaps in care and prevention, because did you actually bill for this immunization that was due for this person, et cetera, et cetera. But it is by far not the end all be all. So it is a measure, but it certainly is not the only measure.
But the HEDIS measures, from the pediatric point of view, they're kind of reasonable. I mean, you got to do your checkups. You have to have a certain amount of checkups up until 15 months. And then after that, they get the pain points of medicine. So the adolescent vaccinations, HPV vaccine, they want to get you to do that. The only problem that I find is that, as with medicine, the window or the possibility of error it's too narrow. They have cutoffs. You have to have the HPV by 13. What if it's 13 in 1 month?
Right.
Or 14. I mean, what's wrong with that? They make it too strict.
Yep.
But it is to do good medicine, I guess. I mean, pediatricians are good at this. I think they invented NCQA stuff. The patient sent them home back in the 90s, I heard, through the AAP. We do this. This is bread and butter peds. What I think internal medicine needs to do in the whole medical community is follow what pediatricians do. If they follow what we do, you guys in internal medicine would probably do a better job.
Well, that's not a fair comparison, because I have a 2-month-old. He's really not going to push back on me putting a needle in his thigh and giving you the tetanus vaccine. but I have a 50-year-old, with uncontrolled hypertension and still eats 2 burgers for dinner and 3 beers. I don't have a shot for that. I can't force that 50-year-old to change his behavior. Behavior change is very difficult. Right. Well, that's what the internist butts up against all the time. Yes. I'm not going to stop smoking because my dad smoked till he was 80 and died from prostate cancer. Okay.
Well, you guys are both right, in my opinion. They're absolutely. So there's obviously lots of things that are special about pediatrics. So one is, of course, and I'm sure this held true for both of you. What did the nicest people in your medical school class, what specialty did they go into? They went into pediatrics. Like the nicest human beings that I went to medical school with, they all went into pediatrics. So you get these wonderfully nice people that go into pediatrics. And that's obviously super helpful, because I honestly think that the positive opinion that and the trust that people have in physicians as adults is 100% the responsibility of pediatricians. Like, because pediatricians are so nice, like you're like the Happy Meal of the medical profession. Like, why does McDonald's do Happy Meals? Because they want you to like McDonald's as a kid, right? Your impressions and your opinions as a child stay with you the rest of your life. Okay, so that's great. That's wonderful. Now, pediatricians also look at children, I think correctly, as, look, you are largely innocent. Like, your brain is not even fully developed in terms of its judgment. So like, if you make a bad decision as a kid, what am I going to do? Am I going to judge you as a kid? No, of course not. And you have really a visceral moral obligation to like help children, right? Nobody wants to like harm children. Nobody wants to neglect children, right? And if anything, like, it's part of your professional responsibility as a pediatrician to identify children who are being neglected. Like, you have to, right? Whereas once you get into adult medicine, then a lot of that goes away. And so a lot of the judgment comes back. A lot of the individual volition of the patient comes into play. And so you deal with a much messier adult environment where there is a very complex interplay. So let me give you a perfect example. Just showing up for appointments, right? Like, if for the majority of adult medicine, like the internist or the family practice doc is like, look, it's your responsibility as a patient to like come in for your visits. And if you don't come into for your visits, that's on you. That's not on me, right? Whereas if you have a kid who you haven't seen in a while, you're going to do like everything you possibly can to make sure that that kid gets into your office, because you're like, are they falling off the growth curve? I mean, I got to figure out what's going on with this kid. And so just at a very basic level, the sort of approach, or the way that pediatricians think in sort of they own the patient. I mean, you guys own the patient.
Right.
And I think that internal medicine can learn a lot from that ownership mentality.
Yeah, and I think because pediatricians are so nice, that's why they get, I don't want to say abused.
Oh, you totally get abused.
by from hospitals, from insurance carriers,
Oh, yeah.
from the medical system, from everywhere. No, you're just a little person, doctor. Just go in your little corner.
Yep. I'll give you a specific example. There was a group of because more pediatricians are employed by hospital systems now. And there was a hospital system in North Carolina that went to their pediatricians and be like, you know what? We're not making ends meet. We're going to cut your pay by 10%. And you know what the pediatricians did? They took it.
Mm-hmm.
They didn't leave.
Yeah.
Like, you want to believe other specialties would be like, you're going to cut my pay by 10%. I'm leaving. Like, I'm out of here.
Yeah. So do you think fee-for-service in primary care is dumb?
Absolutely.
And so
it's
what would you
horrible way to pay for primary care.
So what would you suggest instead?
I really believe in capitation. Okay. I think that you should get, now people say, oh, capitation, that's a bad word, blah, blah, blah. I believe in a amount of money that is given en bloc for taking care of a patient and a patient population. And yeah, you can vary it by risk adjustment. And yeah, you can vary it based upon mutually agreed upon quality outcomes. Dr. Rogu, like you said at the beginning, where the pediatricians created some of their own HEDIS measures. So like, if you're falling down on the job, maybe the amount that you're getting on block is going to be diminished because you're not doing a good job. But the point is that if you're going to own the patient, well, then I'll just, a quick side story. I went to a wedding once that was officiated by a hospice priest. And I'm like, oh, this is going to be terrible. And this hospice priest gave the best message humanly possible. He said, love is spelled T-I-M-E. And we all know as doctors that one of the best things that we can do with our patients is spend more time with them. And the problem is that fee-for-service discourages doctors from spending more time with their patients because they just want to see as many visits as possible. So they spend very little time with them. And as a pediatrician, look, there's some patients that don't need a lot of time, but there's other patients that need a lot of time. And so
who's doing it well? Who's doing that model well?
Who's doing that model well? I can tell you for adult medicine, I don't know for pediatric medicine. Maybe you gentlemen can help me with that. But for adult medicine, The Ochsner healthcare system in New Orleans has made a huge switch over to getting their doctors off of fee-for-service, and they pay their doctors' salary. Pre-COVID, and I've got a doctor who's a surgeon at Ochsner. He's on salary. And they said, and they went out to their health insurance plans and they're like, hey, instead of paying us fee-for-service, we want you to give us capitated payments. And guess what they did? When they did that, they created, because what's the right way to take care of patients? It's out in the community. You don't wait until they're bad and then they come into the hospital. You have to push the care proactively out into the clinics and out into the community. So what did Ochsner do? They opened more outpatient clinics. They increased their outpatient clinic hours. They have a huge bank of nurses that all they do all day long is make outbound calls to the patients who can't make it into the clinic. I mean, how many hospital systems do that? Very few, because they're paying fee-for-service. So because they changed the way they got paid, it changed the way they interacted with their patients. And instead of being passive and being inside the four walls of the hospital and waiting until people were really sick, they proactively went out into the community. And guess what? It worked. During COVID, they had financially, they were great. Financially, they have been so good over the past 3 or 4 years that they bought a competing hospital system in Alabama and Mississippi. They grew.
Let me push back a little bit on that with COVID and capitation, okay? I lived fee-for-service during the capitation time. I was sitting twiddling my thumbs. Very few people were coming in. Our doctors were still getting paid. Our nurses were still getting paid. Everybody got paid. I didn't get paid because I owned the practice, all right? I had some colleagues that are in the capitated model. And I could not understand, one of their employees had COVID, so they closed down their office for a week. How could they do that? Think about it. They still got their monthly check. They didn't care if anybody came in or they didn't come in.
That's right.
So who's taking care of who?
So I really like Chen Med. I like Chen. Yeah, I know, but we all have stories like that.
So,
but I like Chen Med.
But everybody says, what's wrong with having a patient come in, doing the right job, doing good quality medicine, and sending a bill to somebody else to pay?
Oh, what is it? The problem is that it
doing the right job.
It encourages doctors to do too much.
And there's no accountability. You can come in for every runny nose if you got no copay, and you just don't get. You just don't. There's no financial accountability. But Chen Med is doing a great job. They're only adult practice, and they're in multiple states, and they have a really interesting. They're all capitation. They won't take any contracts with capitation, and they limit their family practice internal medicine doctors to 400 patients. That's their panel. And they see their patients one way or another once a month. And they give their patients rides to the office and exercise, stretching classes. And they save money and they make money. And they also have 300 data scientists trying to figure out what motivates people to stay healthy. And that's what, Eric is alluding to. When somebody's paying me sufficient money to invest in the care of these patients, and I get paid when they're well, when they're healthy, then I have the resources to do it. This fee for service is great, but, if I see 35 patients during influenza season, I'm just, seeing patients. I'm rolling through it. I'm not changing the world. They need care, absolutely. But
Correct.
I can't know my panel by 3,000 patients. It's impossible.
I know, but what happens with the capitation world is
Mhm.
the only way you can generate income is if you have a lot of people, okay? And I assure you that the insurance companies will not pay you a good fee for service. Like the DPC models, they charge $200 a month per patient. Yeah, that's good. Whether they come in, they don't come in as many times as you want, talk to me, text me, whatever. But no insurance carrier is going to pay you $200 a month per patient.
But George, they're paying Chen Med to do it, and they have panels of 400 per family practice internal medicine, and they're paid above average salaries. So, so there are people who are willing to do it because at the end of the day, the employer is paying the bill, and Medicare is very interested in saving cost. So there is, but If I have 400 panel, I'm not getting paid $10 per member per month. No way,
And
right?
most of them, I've seen the capitation contracts, they're about $30, $40.
Okay. So it has to be a sufficient quantity that I have a small enough panel and I have the resources to hire the data scientists, the navigators, the coaches to keep my people healthy.
Correct.
Not $15 or $16 a month. I can't do anything with that. You know.
No, and that's not really how it actually works in the real world for capitation, right? So ChenMed it's Medicare Advantage, so that's one, and they're getting like $8,000 a year per patient. Okay, so we're not talking $40 or $200 a month. They're getting $8,000 a year per patient, so it's a ton of money.
That's
Okay,
sweet.
so that's one. So then, you do 400 times $8,000. Okay, so each doctor is bringing in millions of dollars. I think it's like $3.5 million if you do the math on that. So, okay, and then two, now for pediatrics, obviously you're not dealing Medicare Advantage or even Medicaid, right? But in the employer space, where it really manifests itself is really with these on-site, near-site clinics. And so that's where a lot of them are family practice doctors, where they'll take care of, they're not pediatricians. The majority of on-site clinics do not have pediatricians. It's mostly family practice because they want a practitioner. They want a doctor who can take care of the adults and the kids. And that doctor's on salary from the on-site clinic company. And they work at the clinic. And when the patients come into the clinic, by and large, it's zero out-of-pocket cost. And there's no claims run through the insurance company. So they've essentially taken primary care out of the entire insurance process. And in my opinion, that's the right thing to do. I don't even think you fight insurance companies, because you're right, they're not going to pay you. They're going to make their money no matter what. Like, the way that you do it is you basically opt out of the insurance system, and that you get it directly from the employer, and the employer is paying a fixed fee out to the on-site near-site clinic or to the DPC clinic. The way that DPC practices have become really successful isn't by signing up individuals. It's by going to employers and having the employers pay the DPC subscription on behalf of their employees.
And the quality is better. It really is better. We used to think that deductibles and copays at the primary care office were a smart idea. In reality, the deductibles and the copays delay care and make the patient more sick. So it's better to let them in without any friction so that we can address their illness early.
That's right. You want them coming in for every single hangnail possible, because it's really like, okay, you're coming in for your hangnail, but let's talk about your smoking, right? I mean, who makes a doctor's appointment for smoking? Nobody does that. Right. But this probably, it may or may not have been impressed upon you with teenagers, but it's like, if you can get one person to quit smoking, that is a huge success, right? And if they come in for their hangnails, great. If it gives me an opportunity to talk about their smoking, I'll do it.
What do you think the future of healthcare holds in America?
Just to be very pragmatic, it's going to get worse before it gets better. So I don't like, people are like, oh, it's so bad. Believe me, it can get a lot worse. So that group of pediatricians that got a 10% pay cut, like, that's going to happen a lot more. Okay, you've got all these employed physicians, and all these hospital systems are going to run into financial problems. And so it's not just going to be the pediatricians. It's going to be, so doctors are going to get financially squeezed, absolutely more. Doctors are not, I mean, you're already seeing this now with Medicare, with the 3% that they're taking off, right? Everybody's, screaming bloody murder. It's going to be a lot more than 3%. Okay, so it's going to go way down. And access is going to be much more of a problem. And I think, unfortunately, it has to get worse before it gets better, because people don't change unless there's pain, right? Pain causes change. And who needs to change, in my opinion, is the doctors. So the doctors are going to, frankly, Dr. Rogu, I think that more doctors need to stop being employed and start doing. So one of the best examples of this is the Tryon Medical Group in Charlotte. So Tryon's a multi-specialty practice. It's mostly internists, but they do have pediatricians. They do have family practice. They got cards. They got endocrinology. They were employed by Atrium, and they said, this is stupid. The hospital system is telling us how to practice medicine. We don't like that. So they sued the hospital system so that they could separate their practice from it. And they were successful. The hospital's like, yeah, don't sue us. We'll just let you go. And I think more physician groups in America need to follow Tryon's example. And guess what Tryon does? They contract directly with Medicare Advantage, and they get paid capitated payments. Not for all their patients, it's a combination. They got traditional Medicare, they got commercial insurance, but they get capitated payments from Medicare Advantage plans. And so enough doctors just need to be like, take this job and shove it. I'm not going to work for a hospital system anymore, because hospital systems want heads in beds. I mean, they want heads in beds. Okay. Right. And Trion's like, look, we're internists. We don't want heads in beds. Hospitalization is a failure for us. So like, I think that eventually the doctors are going to get so discouraged and they're going to hate it so much that they're finally going to do what they need to do, which is to get out.
Well, I'm hearing more and more young generation doctors, new doctors wanting to go into private practice because of these very reasons. But we hire all the time. I learned if you pay people an appropriate salary, if you do good quality medicine, you make patients happy, good access to care, good HEDIS measures, what else? I mean, you can't not succeed.
And I think a big part of it, frankly, is just the fear with their medical debt. I think that's what it comes out of, is they're like, look, I gotta make some money here, and I need a steady income, and the small private practice stuff, it makes me nervous, et cetera, et cetera. And so like, I can understand that, but I almost think like you got to do it anyway. I mean, like, I'm sorry, like you got to take a leap of faith, and you got to do it anyway.
And the ethos has changed, right? So I am an enemy of every hospital in the world, because I have no better dream than when they develop a breast cancer vaccine, and we don't need mammography, we don't need ultrasound, we don't need cancer, we don't need radical mastectomies anymore. If that means that all the hospitals in America go out of business, so be it. I'll have a party. Okay. And that was how I was taught as a pediatrician. Children go to hospitals to die. Do everything you can to keep them out of the hospital and healthy. That is your mission. Keep the kid out of the hospital. And so it is an unnatural marriage for me to work for a hospital, because my job is to put them out of business. Because when my patients are healthy and thriving, they don't need to go in there. And their job is to make my kids sick and put them on the ward and keep him there and do everything they can to maximize the profit. And we're never going to agree. We're never going to agree, because I'm trying to keep them out of the hospital. And if they want to hate me, and go ahead, write all the nasty emails you want to me today. But my job is to keep kids healthy and out of the hospital. And that's not compatible with working for a health system. But they're also, my mentors said that to me every time a patient got admitted to the hospital. It is a failure of us collectively as pediatricians, this kid's in the hospital. And today, the mentors of the young physicians are telling them there is no life outside the hospital. If you're not employed by the health system, you won't survive. Be quiet and be a good boy. And, I'll take care of you, and I'll make sure you get a hospitalist job when you graduate from residency, or a job at the clinic within our health system. And they're indoctrinating them into being non-thinkers, conformist, and unhappy. And that is awful for society. Awful.
You know why they do that? Because they're easier to control that way.
That's right. That's right. But it's we need to go back to being doctors.
Right.
We are here to keep people healthy and out of the hospital, living their best life, and not just to be cogs in a wheel to keep the hospital beds full and the pockets full at the finance department of the hospital.
But I also think it's a little bit about culture change, okay? Because I have a lot of young doctors that work with us. Notice I said with us, not for us, okay? And they always come and they complain about something. And my go-to answer to them is, so how would you like to resolve this problem? What should we do? And I make them think, and they resolve the problem that I know the answer to anyway, but I let them think.
Yeah.
And I think that helps with culture change. And it's important. They have to feel like they're part of the machine.
Well, every little thing helps, right? So Eric's message helps because he's very successful and he took an alternative path.
Mm-hmm.
the pediatric lounge helps because it shows over and over again great pediatricians across the country doing different things and different models, but still making a difference every day when they take care of a kid.
Right.
We just need more voices to the DPC model. Lee Gross helps. It can be done. The SAS network in Cleveland with Drew, that helps. He's got the same message. So we just have to keep repeating the message, and we have to be evangelists for this new generation of physicians.
Now, I will tell you on a completely separate note, specifically related to pediatrics in terms of what needs to change and the future is, I'm sure as both of you well know, the largest payer of pediatric services in America is Medicaid.
Correct.
Okay. So Medicaid is hugely problematic for pediatric care, hugely problematic. And it's problematic because it is incredibly poorly run. Yes. And you have massive corporations that have cornered the market in Medicaid and you look at Centene's stock chart. I mean, their stock chart, it is remarkably up and to the right. What's weird about their stock chart is that it doesn't deviate. It's literally a perfectly straight line. So like you look at other stocks, the stock kind of goes up and down, it's generally up and to the right, but it kind of goes up and down. Centene's does not. Centene literally is straight up and to the right. Likewise, Molina's is straight up and to the right. And I'm not blaming these companies because the only way they can be successful is if the states go along with it. And so if there's one thing that does need, in my opinion, advocacy, and if there was going to be an area of quote unquote governmental change, it is state level regulation of Medicaid. And there are places like Ohio that are starting to do it, right? Like Ohio is like, Centene was totally ripping us off. And so they sued them and they won and they got a few $100 million back. And then Texas followed suit and New Jersey followed suit. But there is a huge problem and it affects kids. Okay, that's the disaster of it, is that literally is poorly impacting the care of children. So I don't have a magic wand for how to solve that problem, but that is a non-physician problem that absolutely needs to get solved for kids.
Well, what they do with the Medicaids is the managed care Medicaids, right? They manage whatever the plan is. They put the prior authorizations, the referrals, the blah, 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 all that administrative stuff. And then they cry the poverty card and say, well, we're a Medicaid plan, so we can't pay. We have to follow what Medicaid pays. I mean, Medicaid, straight gold card Medicaid, they don't pay well, but they come, they go, they come, they go. There's no problems.
Right.
I don't have to do prior auths. I don't have to do referrals. I don't have to do all this extra stuff.
Right.
Some of them are better where they pay a percentage of Medicare, some 70, some 80%, some even 90. But I remember back in Obama did this where they made parity with Medicare. So pediatricians that had Medicaid lines of business, they were paid at 100% of Medicare. That was good, but that expired after 2 years.
Yep.
Do you think that Medicare reimbursement is fair?
This is where a pediatrician or pediatricians would come up with a better solution than I would. But that's where it would be somewhat of a lump sum capitated payment instead of fee for service for kids. You'd have ChenMed for kids.
Right. Well, this is a very interesting conversation, and maybe we should just have one podcast on this conversation. I would love that. Thank you so much for your time, Eric. I do want to have that conversation on the Medicaid because it's very important, and there's lots of factors. Maybe we'll have a second episode.
Yeah.
This has been a wonderful conversation. Really was looking forward to this episode and really have enjoyed it. So kind of you to have joined us today.
Eric, why don't you tell us your domain name for your website?
Yeah, just go to AHealthcareZ on YouTube. So the letter A, the word healthcare, and then the letter Z. That's the easiest way to see what I'm doing, et cetera, et cetera. But hey, I really want to thank both of you and all the listeners. I mean, keep it up. I mean, you guys are doing a fantastic service. And so I really appreciate you having me on.
Okay, thank you very much.
Thank you for listening. This has been a production of the Pediatric Lounge. On the show notes, you will find links to our co-host and other important notes, as well as a timetable of the topics discussed today. Don't forget to follow us on social media and subscribe to wherever you listen to your podcast. Leave us a great review, as it helps us greatly. In the meantime, we will see you next week. The Pediatric Lounge. The conversations are not intended as medical advice, and the opinions expressed are solely those of the host and the guest.